48th live webinar on orthopedic principles. This time, our guest of honor is Dr. Saurabh Aggarwal from the United Kingdom. Dr. Aggarwal is an orthopedic surgeon based in London, UK, specializing in upper limb surgery, shoulder, elbow, and hands, and trauma. He moved to London in 2004, where he completed his orthopedic surgical training. He then passed his FRC exam in November 2012, followed by the EBOT in 2013. He's triple fellowship trained, shoulder, elbow, hands, and trauma, undertaken at King's College Hospital, London. He's actively involved in academics and runs his own teaching course for the FRC's candidates since 2012. He's also active in research and has done presentations at international, national, and regional level. Presently, he's working as consultant trauma, orthopedic, and upper limb surgeon at Princess Royal University Hospital, attached to the King's College Hospital NHS Trust. It is our great honor to introduce you to Dr. Saurabh Aggarwal from the Princess Royal Hospital. Over to you, Dr. Aggarwal.
Thank you, Dr. Hitesh, for your very kind invitation and for this great opportunity. And welcome, everybody. I'm sorry for the first slide. It was just to show where I work. Topic is distal radius fractures. It's not drudge. So this was just to show this is my hospital, Princess Royal. I'm a shoulder, elbow, and a hand surgeon, and we're part of King's Trust. So we'll straight away go back, start the presentation. So distal radius fractures, as we all know, is a sort of a very common fracture. We see whether we are in UK or India, sort of a bread and butter fracture. And it's a sort of, there's one fracture when we're doing FRCS exams, we are expected to know in and out because it's not a difficult spine or a pelvic fracture. And then this is one fracture which in my practice, at least in London, I see things going wrong because the feeling is it's a simple fracture, it's left over for junior doctors to be done, and then we end up with complications. Now, most important here in the first slide for you to remember is malposition or sort of malalignment, especially the dorsal alignment, which has consequences, which we're going to see in the future slides. Then, of course, other thing to remember is radio-ulnar dysfunction, drudge. So if your sigmoid notch is not congruous with the ulnar head, the pronation supination will not function properly. They get drudge arthritis and they get pain and limitation of movements. Then, of course, tendon ruptures, we know FPL rupture and EPL rupture, we need to be aware of. RSD, of course, can happen. Now, this is an important slide in the sense, we know normal load transmission to the wrist is 80% load goes through radius and 20% through ulnar. Now, problem with malalignment, malposition is the load transmission suffers. And we know whether it's a hip or a wrist, if the load transmission is not right, then patient eventually may end up with arthritis, which needs a bigger surgery in terms of a partial or a total wrist fusion. So if you see with a dorsal tilt of only 20 degrees, the ulna is taking up half the load. Hence the importance of getting the length and the angulation right. So again, in the same, carrying on with the same theme, if the radius is shortened, load transmission again suffers. So even with 2.5 or 3 millimeter shortening, ulna will end up taking almost 40 to 50% of the load. So that is why it's all about, the holy grail in orthopedics is all about load transmission, pain, arthritis. Now we'll start. So what I've tried to do in this presentation is I have put up a lot of x-rays, which I have done in last year and a half, 2 years, to show different approaches, different implants. In the sense, not every radius fracture needs a Volar plate. So which is what is important when they show you x-rays in the FRCS exams, there is no trick. It's just to recognize the fracture pattern, which dictates your approach and the choice of implant. So we'll start with the most common approach, Volar approach. Now, it's a very familiar approach. This is what we do more often than not in a distal radius. Whether you're a hip surgeon or a wrist surgeon, this is what you end up doing. Now, we know the volar surface of radius is concave. Advantage being, sort of plate can snuggle into that volar surface. So your flexor tendons, your FPL especially, is far away. And obviously, sort of familiar approach as we spoke about, and less disruption to blood supply. But equally, the disadvantage of volar approaches is still, it's a relatively difficult approach to get right compared to a dorsal approach. I know it's counterintuitive, but volar approach is harder than a dorsal approach if you speak to a proper pure hand surgeon. This is just for completeness sake in case they bring it up in the exams for you guys. So like your elbow, like sort of, you can think of your wrist as 3 columns. Rikki and Regazzoni from Italy, if I remember in 1970s or thereabouts, they first spoke about this 3-column concept. So the radial column is important for your ligaments, all those radio sort of lunate ligaments and radiocarpal ligaments. Intermediate column lunate, capitate lunate and lunate fossa fragment of radius. That's important for load transmission. And that's why when you're doing your fusions, we always say we want, important factor there is radius should fuse to lunate and to capitate. It is for this reason. Ulna column, ulna head and neck, TFCC, that's important. That gives you your rotations. And of course, 20% load is going there, but that column is more important for rotations, i.e., in some cases, very few, seldom cases, if there's an ulnar fracture that needs to be addressed as well to give you your rotations back, pronosupination back. Now, our volar approach, some tips and tricks which I've learned making mistakes throughout the years. So of course, in the exam, how it works is you're going to talk about your ATLS principles. You're going to talk about how you will see patient in A&E, which will come to as we discuss x-rays. But once the patient is in theater and your sort of checklist is done and your sort of clean and draping is done, and if you've decided to do a volar approach, important is after you've done your skin and fat, preserve your FCR sheet. I see very commonly when I'm training junior doctors here, tendencies to go through the sheath of FCR. Preserve it, go radial to it. The importance is, if you go through the sheath, once in a while, you will cause tethering. FCR will tether, which means you will lose extension. So it's important. I've done 2 cases in last 4 or 5 years where I had to go in again, do a tenolysis for the FCR tethering to give patients movement back. So it's important. Brachioradialis is another thing to consider. I don't, in my practice, I don't release it in every case. But if there's a marked radial translation, to get that radial styloid fragment back, I will release brachioradialis. If I do that, the release is from proximal to distal. This is important because if you do the other way around, tendency is you're going to come from distal to proximal. But if you do that, there's a small chance you can damage first extensor compartments. Then third thing, and even you'll see in my x-rays, a plate is not parallel to the shaft. In the sense, you will notice plate tends to deviate towards ulna all the time. But if it's parallel, it helps you to get your perfect radial styloid screws. So pay attention to the radial plate, where it is in relation to the shaft when you're doing your II images. Then drudge is very important. As we said, drudge arthritis, lack of pronosupination. So when you're putting your screw in the lunate fossa fragment, remember sigmoid notch is concave. So be like your typical play font when you're putting your plates. So be aware and make sure screw is not in the drudge. Very important. Then other frequently asked question in the exam is, what screws do you do first, proximal or distal? Answer is you can do either depending on fracture pattern. So sometimes you can use plate as a reduction tool. For example, if you have a distal radius fracture with a marked dorsal displacement and angulation, and it's not correcting with either manipulation or using your McDonald's when you've opened the fracture. Then in those cases, I tend to put distal screws first. Proximally plate is a bit elevated. And then once you've done 3 or 4 screws, you've got enough purchase in the distal fragment. And remember, fragment is still dorsally angulated 10-15 degrees. Because the proximal end of the plate is not sitting on the bone, it's like higher up. Then if you use a cortical screw, the only way the proximal end of plate comes down to the bone is by ensuring your dorsal tilt is corrected. It's a very handy little technique, and I employ it all the time. And then finally, pronator quadratus. We take it off the radial side. So what I'm trying to say here is I, a hand surgeon, will pay attention to when I'm taking it off. I try and preserve the muscle belly as much as I can. And then I never endeavor to reattach it to where I took it off from. I will mobilize it and attach it on the volar rim. The reason is that's where you get FPL ruptures. So these are all little tips and tricks, but they're practically very important, bails you out from a lot of trouble. And equally, if you bring those up in your discussion, when you do a radius plate or a volar approach, you convey that you are a thinking surgeon and it gets you extra marks. So let's see some examples. Sort of theory, rest theory you all know. Important is volar approach, how you do it, tips. So let's talk about some examples where you do a volar plate. So this was a 57-year-old lady, had a simple mechanical fall, very common sort of a routine injury you see in your accident and emergency. So here you can see on the sagittal x-rays, it's a volar Barton fracture basically. You can see how lunate is tending to fall off in the front. So even if you reduce it nicely, put a plaster, chances are it's going to slip back again. So this is one case you need a plate from the front and you need to sort of buttress it from the front if you like. So again, in the exam, you will talk about ATLS. You're going to go to any CP, this patient according to ATLS principles. You'll make sure it's a closed injury or is it an open injury. You will examine median nerve. You'll make sure it's an isolated injury. Once you've done all that, then you come to the discussion for this fracture. So you need to bring up ATLS principles in every sort of a case that you talk about. So this was a pretty straightforward case. You use a plate from the front. And if you now see lunate orientation is right, it's pointing in the right direction and it's sitting onto the radius. So, and approach is as we have discussed. Now, so let's see this example now. She's a 58-year-old lady. I think I treated her way back in 2017, coming up to 2.5 years. Straightforward mechanical fall, isolated injury, came to A&E. Now, if you see here, you can see a fracture line in the PA X-ray. And on the sagittal cut, you can see there's something going on there. There's a little bit of depression. It doesn't look right. So important is in a distal radius, what I've realized over the years, if you're ever in doubt, get a CT scan. Because CT scan will tell you what approach to use in some cases. So important thing here was volar cortex is intact. If you see, I put a lot of sagittal cuts here in your scaphoid and lunate fossa fragments. In all the cuts, scaphoid, the volar cortex is intact. You've got a die punch fragment there, and you've got dorsal condition. Yeah, okay, is the screen visible now?
Yeah, perfect.
Sorry about this, guys. I think our network is a bit poor in the hospital.
Yeah, that's the reason.
Yeah. So I was just saying, so in my practice, I try and do a volar approach if I can avoid a dorsal approach for the reasons which I was just mentioning. So in this case, what I did was, like I would do, all of us would do in a tibial plateau, I put a K-wire pointing towards the die punch fragment. That gave me an idea as to where to make my window in the volar cortex. Then you make a window. I use Acumed in my practice. They've got this very nice curved punch, which allows me to go through the window almost at right angles. You jack up your die punch fragment. And as you can see in this third slice, once your articular surface is restored, whatever gap is there now, same like in your tibial plateau, you can pack it up with DBX and calcium chips. And then once you've done that, life is easy. Then you can do your sort of going next slide. So then you can do your Volar plate. All right. Now, see, as I was telling you, plate always tends to drift ulnawards. And what effectively that means is, because it's drifting ulna, this styloid screw will tend to come out. You can see there's a thin margin of cortex there. So obviously, because I was aware as a hand surgeon, if this screw was a bit more out, it'll irritate first extensor tendons. So it's really important to get this plate parallel, which allows you to get your perfect radial styloid screws. Other thing to remember here is your drudge. If this screw is again 5 millimeters further ulnawards, before you know, the screw will be in a sigmoid notch. And then patients obviously will have a lot of pain on pronosupination. So be aware of those little sort of things. This was an X-ray 10 weeks post-op saying it's all healed up nicely. You can see the articular surface very nicely restored. So those were the two examples I wanted you to know, that Volar approach you can still use even for, in some cases, with dorsal combination. Idea is to avoid dorsal approach as much as possible. But yes, if you have to, then you have to. Now, coming to dorsal approach, Volar approach, a big problem is radial artery. Because when we're putting a vest or retractors, they have sharp ends and radial artery is an issue. So another little thing to remember is when you finish your surgery, take your tourniquet off, make sure radial artery is patent, very important. Secure, have a good hemostasis, and then close the wound. Dorsal approach doesn't have this problem. There are no big nerves, there are no big vessels to worry about. Yes, of course, there are cutaneous nerve, dorsal cutaneous radial nerve branches and dorsal cutaneous ulnar nerve branches, which you need to be aware of. And then, as I said, if you talk to a hand surgeon, it's an easy approach because skin is very close to the bone. You just have skin and fat, make two nice flaps. Retinaculum, you go through your EPL, third compartment, and leave EPL out at the end. And then easier to reduce your sort of dorsal fragments and to restore your volar tilt. Disadvantage, as we were talking before, dorsal radius is a convex surface, which effectively means when you put your plate, your tendons are very close to the plate. So they can get irritable, they can get tenosynovitis, you can have tendons stuck onto the plate if you scratch the plate. So that's important. Make sure there are no scratches on the plate, handle plate very gently. And then of course, 1 in 3 patients, you may have to go in to take your plate out. So let's see some examples for dorsal approach. So this was again a 61-year-old lady, gentleman rather, beg your pardon. He had a mechanical fall, and as you can see, I just saw him 10 days back or so, rather a week back. So if you see on an X-ray here, fine, your PA X-ray, and by the way, wrist is always a PA X-ray, not AP. In the exam, you have to say PA. And how you know is in a PA X-ray, styloid process to ulna is the most ulnar structure. If by mistake your radiographer has done an AP view, and then if you are careful to sort of, if you watch the X-rays, styloid will not be the ulnar structure, it will be somewhere here. So wrist should be a PA X-ray, and now you know the difference between PA and an AP X-ray to the wrist. So you can see it's a straightforward sort of a comminuted distal radius comminuted intra-articular fracture. If you see the sagittal X-ray, I thought looking at the X-ray, it's a big sort of a dorsal fragment. It doesn't look that comminuted, but it's a big dorsal fragment. And then you see lunate is tending to sort of come out dorsally. So as I said, if in doubt, get a CT scan. And then if I show you a few sagittal cuts, you can see how lunate is plowed in. But look at the size of the fragment on this cut. So fairly a big chunk. And this just confirms what you saw on a PA X-ray. And then again, I've put some 3D recon images. It shows you sort of big chunks to the dorsum of the radius. So this patient problem here is more of dorsal combination. So this you cannot address from a volar plate because there's a lot of translation as well. So this is a case where a dorsal approach needs to be done. So I only have eye images because I just did it 2 days back on Thursday. Important here is a dorsal approach. So let's talk about the steps to the dorsal approach. So again, in exam, you have to talk about consenting. Consent is very important. Then when you are in theater, you need to talk about positioning. In this case, it's going to be supine, arm bow, tunicae. You need to talk about antibiotics. You need to talk about wrist block. We do a WHO checklist here. I'm sure you're doing your checklist back home. Mention those. And once you've done that, once you've cleaned and draped, then you come to the approach. In terms of approach, is going to be a midline dorsal incision to the wrist. With a midline incision to the wrist, you can do you can almost do anything. You can do all your rheumatoid work, whether it's a wrist replacement, a wrist fusion, a drudge replacement, your Von Jacksons for tendon transfers, partial wrist fusions. You can do pretty much everything through a midline. So stick to one incision, even in your practical day-to-day sort of practice and for exams. And I always say in dorsal approach, for exam purpose, you need to remember 3 steps. First is you need to protect your cutaneous nerves, your radial cutaneous nerve and your ulnar cutaneous nerve. For that, you need to make nice flaps. So skin and fat. Remember, blood supply to skin comes from fat. So if you've got good flaps, your blood supply to skin is preserved. Your wound will heal up very nicely. So you go right with your knife, you go right down to the retinaculum. Then with your gauze pieces or with your knife, I take a wet gauze piece, make 2 nice radial and ulnar flaps. So your cutaneous nerves will be in those flaps, preserved in those flaps. So that's first step. Second step is your retinaculum. Retinaculum can be cut in many different ways depending on approaches. For exam purpose, retinaculum, just remember one thing, you go between 3 and 4. So practically you go through the third, you take your EPL out, and then you do a subperiosteal elevation of your 4th compartment, which goes ulnarwards, your 2nd compartment, which comes radialwards. And then your whole distal radius is looking at you. The third step, which is not relevant to my talk here, is the capsule. So if you're addressing your carpal bones, your slack wrist, your snack wrist, your partial fusions, your total wrist fusions, then you need to incise your capsule. Again, can be done in many different ways. Burger flaps, your modified Mayo flaps. For exam purpose, just say a radial base flap. So 3 simple steps, and in exam, it'll bail you out. So in this case, we did the 2 steps, good flaps, retinaculum between 3 and 4. And then obviously you reduce your fragments. And then again, I've saved a PA view to show you. This is a plate from the dorsum. You can see very clearly from here. Plate from the dorsum. I've deliberately saved oblique view to show you the articular surface. Translation doesn't matter, but the surface is restored. And then this is a proper lateral view, again, to show your articular congruity. So that is important. And here, if you see on a PA view, the sigmoid notch is okay, congruous to your ulnar head. Again, little tip, every time you do a distal radius, always check your pronation supination at the end to make sure you've got full pronation supination back. This is a good habit, good practice. So this was the operation. So this is the case with dorsal combination where you do a dorsal approach and a dorsal plate. Then let's see another example. So these are all the examples now for dorsal approaches. But as I said, there are lots of different things you need to think about and do. Not every case will need K-wires or a plaster or a Volar plate. Similarly, not every dorsal approach equals a simple dorsal plate. So let's go through this example now. The 28-year-old fit and healthy young man, simple innocuous sort of a trivial fall. And again, a year ago, May of 2018. So he came with this injury. Now, if you're not careful, it looks fairly benign. Looks like something you can get away without operating. But as I said, if something, look at what's going on here on the sagittal X-rays. capitate is not sitting right onto the radius. No harm getting a CT scan. And when I got a CT scan, you can see so I've got these sort of coronal cuts. You can see the combination is very distal. Yeah, normally you get a fracture in this plane. Look at how distal it is. And if you see your sagittal cuts, that's scaphoid. So scaphoid fossa fragment. Again, very, very small bone there. Scaphoid, very, very comminuted. One piece, two piece, third piece, very distal. And then you can see your lunate. So lunate fossa fragment, similar story. Three pieces, all very distal. So this patient had combination in both the planes. He's young, he's 28. This is not the fracture you would want to sort of manage in a plaster. Now, important thing is, if I decide to, let's think of a Volar plate here. If I do a Volar plate, I don't think personally your screws can have a bite in these fragments. And then how do you catch your dorsal fragments? Even if I do a normal dorsal plate, which I just showed you, those screws will not catch this. There's going to be no purchase in these fragments, right? So what do we do? One option is an external fixator. You use your ligamentotaxis principle, you jack it out, and then you put an X-fix. Problem with X-fix is you need to leave it on for 6 weeks. Wires can back out. Infection is an issue. Cumbersome. It gets caught in bed sheets. And then when you're doing it, superficial radial nerve damage. So personally, I am not a big fan of X-fix unless there's a big open injury or something. In my practice, I'll use X-fix once in 2-3 years, if you like. So instead of an X-fix, it can be used an infix, like a plate, which can bridge the joint. So it's an infix plate. But the advantage here is sort of no, because you have a covered wound, no chance of infection, easy for patient's end. But the only problem will be because it's bridging the joint, patient can't move the wrist. So at 3 months, you need to take it out and you use that opportunity because wrist is going to be stiff. There'll be a lot of dorsal scarring, capsular contracture. So you use that chance to manipulate it. And I also, because all the, so you would have gone second time to take the plate out. So all the problem, all the scarring is dorsal. So you use the chance to do a dorsal capsulotomy to give that palmar flexion back, because extension will not be an issue here. Problem will be scarring at the back, so loss of palmar flexion. So this is what I do. Other important thing to note here in a PA X-ray is, so problem with ligamentotaxis, whether you do an X-fix or an infix, if you stretch the ligaments too much, we all know patients are in a lot of pain and they can get CRPS. So important thing on table when you're doing this under your II images, to make sure your radiocarpal joint and your midcarpal joint, if you stretch your ligaments too much, that space will increase a lot. So pay extra attention to that. There was one case 4-5 years back, when it was stretched a lot, patient was in a lot of pain next day. So we had to go back in again, reduce the space, and patient was fine. Same with the X-fix. So if that happens, you own up to it and you need to reduce the traction. Yeah. Then another case, 36-year-old builder, he fell off a ladder on axial load injury. And you can see here, there's a lot of combination, both in the sort of a PA X-ray and in the lateral views. A lot of combination, and lunate is tending to drift dorsally. If you see, it's almost sitting on the dorsum. So this, so again, as I said, any complex radius fracture, you get a CT scan. And again, I'm not saying it for time's sake. For every fracture, you have to say ATLS, you go to A&E, you make sure you need to know whether it's a closed or an open injury. You need to examine nerves with special relevance to median nerve. You need to look for compartment syndrome in very smashed up fractures. And then once you've established it's an isolated injury, then you comment on those X-rays. So in the CT scan, we'll come to sagittal cut in a minute, but if you see the coronal cuts, lots of combination, and very distal. So volar, dorsal plate, none of them will be able to have a purchase in these fragments. Sagittal cuts are a bit interesting in the sense if you see this fragment, lunate, so lunate fossa fragment, articular surface here is completely derotated, is pointing in the wrong direction. Now we've established two things here. First, a very distal combination, not amenable to a normal plate. So we saw that in fixed plate. So we can do an infixed plate from dorsum, i.e. a dorsal approach. But if you see this fragment there, this is not going to correct itself. This is a Volar fragment. You can see from here, this is a Volar fragment, if you see the orientation of the bones. So that means I'll have to go Volar also. So this is a case where you need dual approach, dorsal and a Volar. So we've seen examples of isolated Volar approach, isolated dorsal approach. Here you need dual approach. So like a plate sandwich technique, you sandwich the fragments with plates, either plates on both sides, or in this case, I use the anchors, which I'll tell you why. So in this case, important is I went dorsally first. Like the last case, I reduced it. I put a plate there, a couple of screws, 3 screws in the metacarpal, couple of screws in the shaft. But important here is, as I told you last time, two things. One, here I've tried to show the scaphoid's articular surface, and in this view, the lunate articular surface. So we've got articular surface to a reasonable congruity. That's first thing to notice. And even on the lateral X-rays, you can see the articular surface. Second was overstretching of ligaments. So always pay attention to your radioscaphoid joint. We've not stretched it too much, and see your midcarpal joint is not stretched too much. And how do I know I've got it out to length? See the space there. So I know I've given a reasonable amount of traction, but equally not excessive traction. So that's important. So once I've done the dorsal approach, I came back from the volar side. Now that big fragment we spoke about in the last slide, this fragment, lunate side. So came back on the volar side, corrected the rotation. Now I could have used a fragment specific plate, which is another arsenal for you as a hand surgeon. But I feel in wrist surgeries, less is more. I don't want to put two bulky plates here. So I put a couple of anchors, taken a bite in that fragment. So if you see here, this is attached to the capsule. So once I've reduced it, take a bite in the capsule, and with the thread, it'll keep it sort of buttressed, if you like. And if you had used any plate, whatever you have, would have done the same job. So I did a proper dorsal approach and a mini open volar, couple of anchors, and that fragment is all corrected now in the right orientation. So again, this case only came on 8th of April. So I don't have sort of 3-month X-rays to show you. Then another case, a 61-year-old gentleman. So again, now these slides are borrowed from a colleague of mine. He was referred to us from a different hospital. That's why we do not have his X-rays. But I can show you the CT scans. So on coronal cuts, you can see there's a lot of combination. Again, very distal combination. And here, that's a reasonable size fragment there. On the sagittal cuts, you can see sort of on the dorsum reasonable fragment and see such a nice fragment. So this is the one because it has reasonable fragments on the coronal cuts and on the sagittal cuts. I can do a normal plate. I don't need to do an infixed plate. And again, because of the dorsal combination, idea is to do a dorsal approach. So, and sorry, before I go anywhere else is, you can again see dorsum has reasonable 3 big chunks. So I'm sure if I put a simple dorsal plate, I'll have enough purchase in the screws. And this is a sort of a huge radial styloid fragment there, there, and there. Yeah. So we did a dorsal approach. We got this plate on, got the plate on, PA X-ray, lateral X-ray. What I want you to see is this plate goes really right to the rim, Yeah. So, and this wire is holding my styloid there. So you put one screw and sort of you do II images. I've not put, and you can see this sort of, I've not put that image, but always put a wire through the last screw to make sure that screw is subchondral. Once you're happy, rest is easy. You fill up the plate with screws, and that big radial styloid fragment there. And we've used this small sort of a contoured fragment specific radial styloid plate. And you can see these x-rays there holding that big radial styloid into place. So this is an example where I've introduced you to a new plate, now fragment specific. Now, idea is not, because I know you guys will be taking exam. I don't want sort of what I'm trying to highlight here is, if you're shown a radius x-ray, there's no trick normally. Once you understand the principles, tendencies to jump and say, I'll put a Volar plate, or you think, oh my God, what's the catch? Why have they shown me this x-ray? So the catch only can be combination. If the combination is very distal, which you can easily see on a CT scan. So if in doubt, ask for a CT scan, see the combination. If the combination is very distal, you need an infix plate, simple as that. If the combination is very sort of, if the combination is dorsal, but with reasonable chunks, you can do a dorsal plate. And then other arsenal is fragment specific. If it was a pure radial styloid fracture, which was very displaced, you could have done a fragment specific plate. If you don't have that in your hospital, you can put simple 2 screws. But idea here is to appreciate fracture pattern. Styloid, your lateral column, your lunate fossa fragment, i.e. your sigmoid notch, because your drudge has to be congruous at the end of surgery, which is what gives you rotations. So, and then finally the ulnar column, which I'll show you in some other slides. So once you understand the principles, rest all is easy. You're not doing a dorsal approach in the exam in front of examiner, but you need to know those 3 steps or 2 steps in case of dorsal plating. And then, just need to describe it sensibly. So again, very recent, last month. So you can see this is 2 or 3 weeks post-op. So it's all holding on and it should now go on to heal. And again, look at the sigmoid notch, it's all very congruous. So always check pronosupination at the end of every surgery as a habit. Then let me introduce you to another fracture, impacted radial styloid fracture. So we know TRAS, radial styloid, parilunate injuries. So every time you see a radial styloid fracture, instinctively you should look for a scapholunate ligament injury. So look for those Terry Thomas sign and scapholunate steps. So now this lady, again, 5th of May. So I've tried to put very recent x-rays. So she is young, I think in her mid 40s, but she's alcoholic, she smokes. So not the best of candidate for a big surgery. Anyway, she left it at home for 2 months. Then my colleague showed these x-rays to me. And important thing here is the styloid. So this is a sort of impacted. So scaphoid has die punched into the styloid there. So it's a radial styloid fracture. Every time you have that fracture, you look for scapholunate ligament. And if you see very carefully, there's a step. See how far this scaphoid has come down into radius, whereas you have preserved radiolunate space. So there is, I pretty much feel there's a scapholunate ligament injury. But because it's already 2 months down the line, we're getting an MR arthrogram just for medical legal purpose to document and to let the lady know that it's a severe injury. Now, if it was a day 1 injury, then in this case, because see, again, this is a mush. These are such tiny fragments. Even if I open here, I would struggle to reduce it sort of with either a lateral approach or a volar approach. And then other associated factor here is scapholunate ligament. So if it's a day 1 injury, this is one case you can put a wrist scope in. Assess your scapholunate ligament, whether it's partial or complete. Debride it. If it's complete, you know you need to repair the scapholunate ligament. And while your scope is in the radiocarpal joint, you can use that opportunity like I showed you before, to take a little punch, either make a little window here or from there, elevate this die punch fragment, pack this with a bit of calcium chips, and because your scope is in and you've sucked out all the blood, you can see the articular surface with the scope. Once your articular surface is restored, then you can do your open approach, a dorsal approach in this case, to repair your scapholunate ligament, and then just put a simple screw or that fragment specific plate or any other plate, semi-tubular plate, if you don't have those fragment specific plates, or simple screws, doesn't matter, headless screws, any headless screw will do here. So important thing here is not every radius fracture needs a volar approach. Not sort of, you need to use these various plates which you have in your arsenal for different fracture patterns. From exam point of view, because I know some of you may not have done a dorsal plate. I hadn't done a dorsal plate. I had seen few, I've never done myself when I was doing my exams 8 years back. But important is, once you know that you should ask for a CT scan, and depending on where the combination is, you need to decide an approach and the choice of plate. Once you can describe that much, that's all we need to know when we are examining in the sort of exams, to know that you are a thinking surgeon. So remember, you can have scaphoid die punch, very unusual injury. I'll see one in 5 years maybe. Equally, you can have lunate die punch, more common injury. Look out for those lunate die punch, because if this fragment was depressed, you will have a positive ulnar variance. Patient will have ulnocarpal abutment. So those are the ones you need to jack them out, and you can put a small plate here, those fragment specific plates here. Fragment specific because it is specific to lunate fossa fragment. Then I showed you a styloid fossa fragment plate. So that's why they're called as fragment specific plates. Then we come to your ulnar column, your third column, Rikki and Regazzoni ulnar column. Now, remember, very commonly you will see a styloid fracture because of TFCC avulsion. By and large, we never address a styloid. Once you've got your radius back in anatomical position, your styloid will heal up. You will not get drudge instability because styloid tends to heal up. But once in a while, if you get an ulnar neck fracture and it's very displaced, then you need to address the ulnar column. You need to address the ulnar neck fracture to restore again your drudge. Otherwise, rotations won't be proper. So this again case was from 2-3 weeks back. This lady, this is again 28th April, beg your pardon, so maybe 3 or 4 weeks back. So this lady came with she had a simple volar plate. She came with a periprosthetic open fracture. So a big long cut in the front. I've taken that plate out, put a long plate. But important here, this slide I had included to show you the ulnar neck. So this was actually almost completely displaced. So through the same volar approach, I've reduced it and put wires, and I've shown you a PA view, a sort of an oblique view and a lateral view. So yeah, so if you have a styloid fracture, you can put a small screw. I don't like screws through styloid, or do a tension band. If you have an ulnar head or a neck fracture, I like these K wires. I don't like anything too bulky there. Take them out in around 3 weeks and then get them moving, take them out of plaster. And if you had, if you have a distal fourth, distal fifth ulnar fracture, then you need to put a plate. In distal, EDM tendon is there, your ECU tendon is there. So patient may get ECU tendinitis or EDM tendinitis or irritation. So remember that it's a very simple approach from the volar side. All you have to do is, and it gives you a good skin bridge because or you can get, so for a radius, you do your FCR approach. To put a plate on the volar side, you can still put an incision on the side of the ulna and then lift the FCU towards radius. And that's the only muscle. Then you can easily put a plate on the distal fourth or distal fifth of ulna. still maintaining a good skin bridge. So that's one little thing to remember. And then, yeah, so I think we've addressed all the three columns. We've spoken about two approaches and lots of different plates to address different fracture patterns. Now, finally, what all can go wrong? We said 31% complications. So one of the important complication is your dorsal malalignment. So again, just for completeness sake, if you see a distal radius fracture in a clinic, if I put 2-3 complications so that you know the whole journey of that distal radius. So for example, again, this is from September of last year. 61 lady fell down. She came to our accident and emergency. Important, anything interesting here is your lateral x-ray. You can see there's a dorsal tilt of 15 degrees, maybe 20 degrees, but you can see capitate is completely falling off the dorsal cortex of radius. So we know something has to be done. They gave her a hematoma block. They reduced her. You can see plasters after reduction. You can see they partly corrected it. And then again, this was from 9th of October. By the time December came, she had slipped back to the original position. And you can see capitate is completely falling off. So at this stage in December, I was referred this patient from my colleague, lower limb colleague. She's 61, she's young, she's healthy. You can't ignore this. Again, because load transmission will suffer, she will get arthritis. And she will also get a lot of problems with flexion here. You can clearly see lunate will start pinching or abutting the volar rim. So this lady needs a dorsal, sort of a distal radius corrective osteotomy. So I got a CT scan. You can clearly see, look at where the capitate is. It's completely fallen off. She's never going to have a good function like this. You can see 20 degrees of dorsal tilt, effective 30 degrees. So again, a dorsal approach, osteotomy there, get the tilt back. And if the gap is huge, I use a iliacrest bone graft in my practice. If gap is little, you can just take some graft from locally and just pack it there. Yeah, and again, if you're not doing a huge correction, these days I'm also doing volar approaches. Because again, dorsal approach problem is 1 in 3 patient plate has to come out. So again, dorsal approach was used, and you can see I've used dual plates. You can use a simple dorsal plate also, the one I showed you before. You can use any plate. Plate is not an issue. We have special corrective osteotomy plates as well. And important here is sagittal X-ray. It's showing lunate is back onto radius. So you know load transmission will be fine. This I wanted to put a video. I haven't been able to. Maybe I can after the end of lecture. But other problem is FPL rupture. Now, the reason flexor tend, so yeah, okay, again for theory purpose, 2%. So, and then it'll present after a year. The reason it presents after a year is FPL keeps rubbing onto the volar rim or onto a screw, takes a year for it to rupture basically. Then patient comes suddenly and patient is not able to flex the thumb at IPJ. And again, look out for your screws. Important is once you put all your screws as a routine, as a habit in any plate, make sure they're all tight. Because even if one screw backs out, you need to go in again to take the screw out. So another general anesthetic which could have been easily avoided, or it can irritate a tendon. Yeah, as I said, I do have the videos. I can put them back on. I didn't have chance to put them back on. I can show you the slides and the video if you give me 5 minutes after the lecture. But yeah, so look out for FPL rupture. Other issue is EPL rupture. EPL rupture can happen at the time of injury or a couple of months later. EPL rupture can happen whether you have a dorsal displacement because of the sharp fragments or even in a completely undisplaced distal radius fracture. Because hematoma is all, because there's no capsular rupture. So hematoma is all confined within the capsule and can cause EPL rupture, sort of because blood supply stops to EPL. So remember FPL rupture, remember EPL rupture. EPL rupture is easy. We've all done EI to EPL transfers. FPL is a bit unusual. You take FDS to ring finger and you transfer it to FPL. Yeah, and with normally very good results. In my practice, I'll see one case every year, but they tend to do very well and patients are very grateful. So look out for those prominent screws. That's very important. Finally, I use Acumed in my practice. You can use any system. I don't have any conflicts with interest with Acumed. The reason is it's a complete package. It gives me all the place for all the fracture patterns. I don't need to go elsewhere. So just as a recap, so this is our Volar plate, which I showed you before, which you use from the Volar surface. This is our dorsal plate. You can see dorsal surface is convex. See, it's contouring to the dorsal convex surface. Fractures with dorsal combination, this is what you're looking for. These are put 2 fragment specific plates. That's my radial styloid plate, which we had used in the before X-ray. This is a dorsal rim plate. Again, from the dorsum. This is from the radial side for those specific fragments. There are other fragment specific plates which you can put from the volar surface also for lunate dye punch, for scaphoid dye punch. Then this is the distal ulna plate, which you have a volar plate and a dorsal plate, whichever you want to prefer. And then this is the bridging infix plate, which I've been showing you all along. Of course, you have an X-fix. You always think of KY as an exam. If it's a simple extra-articular fracture, you can get away with KYs. Remember the principles of KY fixation. Remember, you need to know, they'll ask you how the configuration across the fracture site. That's very important. Problems with KYs, infection, they can back out. You need to do serial X-rays for first 2 to 3 weeks. Wires come out at 6 weeks. Versus plate. Advantage of a plate is, I in my practice just do 1 X-ray at 3 weeks. Usually, maybe depending on combination and patient characteristic, maybe 1 at 2 months. Otherwise, you don't. I give a plaster for 10 or 12 days to allow edema, swelling, and pain to settle down. I'll see them at around 12 days or 2 weeks. Then stitches come out, or a wound check gets done if I put monocryl stitches. And after 2 weeks, they don't need a plaster. They get moving. I may see them once at 2 months for their reassurance. Sometimes I don't even see them. After first visit, if patient is sensible, you just, get an X-ray at around 6 weeks, 2 months also. But plate has lots of advantages. You don't need to see them frequently. No need for plaster. They can wash their hands. They get their movements quickly. They can go to office work quickly. So think of all the advantages of plate. Disadvantages, big cut. Plate can have its own problems, FPL ruptures if you're going from volar surface. So pros and cons to both. This is what they look for when you're answering, whether you want to put KYs or plasters. And finally, think about ATLS. You have to mention ATLS, open, closed injuries, median nerve examination in the heat of exams. Sometimes it's hard. So you need to do 1 sensory component and 1 motor component. Sensory is the quickest. So always start with sensory, whether you're doing a brachial plexus examination or a simple median nerve examination. So think of compartment syndromes. And then think of your approaches. Think of what plate you want to use. Think of all the advantages, disadvantages. Thank you.
Thank you, Dr. Saurabh, for that very exhaustive but really brilliant presentation. You've shown some fantastic cases that you've done. I mean, it's really enlightening for a lot of new approaches. There are a couple of questions that have come up. I'll just
thank you, Dr. Hitesh.
I'll just go through some of those. One is, you've put a lot of emphasis on dorsal plating as well, but the risk of tendon attrition and rupture isn't it a bit high with the dorsal approach?
So dorsal, these days, we have very good titanium plates. So we are using a 4th generation aluminum. It's a bit expensive, but what it allows us to do is a very thin, low profile plate, which are biomechanically very strong. So I did say 1 in 3 plates need to come out, but I have done a couple of wrist fusions. Like in my practice, maybe 1 in 5 needs to come out actually. So these plates are so inert, tendon tends, for them it doesn't exist actually. Important is scratch profile. If for some reason we have scratched it, that's where tendons start seeing that plate, and then it gets tethered or it gets irritable and problems come. Occasionally, yes, you can get tendon tends to tether down. So idea is not to give plaster, depending on what you're doing. If you're doing a total distribution, then I do give a plaster for 6 weeks. Otherwise, you take plaster off quickly, around 2 weeks. If the fingers are moving, tendons will not stick. And if you've dissected properly, if you've taken off your retinaculum properly and your tendons are in their tendon compartments, then they glide very smoothly and you will not have irritation. In fact, with a Volar plate, which I should have also mentioned, I tend not to drill the dorsal cortex, because the moment you drill it, one, you're creating that bone debris very close to extensor tendons. Second, if your screw penetrates, that's where because screw penetration equals problem. Whether screw backs out of plate, or from Volar surface, screw penetrates the dorsal surface, that's where we are asking for trouble. So I will not drill the dorsal cortex. If by chance I've drilled it also, whatever you measure, take 2 millimeter less. Or you can do a skyline view to make sure you've not breached the dorsal cortex. So that's another thing with imaging. Your articular surface view, i.e. elbow is at 40 degrees like this. It's not flat on the table. It shows you all the screws are subchondral. And your skyline view to make sure your screws are not gone through the extensor cortex, dorsal cortex. So dorsal plate is very safe if used from a sort of a proper company, like those new generation ones.
Okay, but you say at least you have 1 in 5 plates need to come out.
Yes, but when you have to use
but those
them,
are due to tendon problems or?
Yes, sometimes tendon tends to still stick, or patients are not. So when they want to flex the fingers to make a fist, because the adherence is at the back, they are not able to fully sort of flex. So those are the times, if you have to go in, you take the plate out, you do tenosynovectomy, you do tenolysis, make sure tendons are gliding nicely, and you take them out. For example, Dr. Hitesh, this bridge plate which I showed you.
Yeah.
This has to come out because it's bridging the wrist joint at 3 months.
Yeah, that has to come out for sure.
Now the reason I have taken it out is obviously to allow wrist joint to move, but not once. I've used around 6 plates in the last 2 years. Not once there was a tendon adhesion, even at 3 months. So tendons, if there is no scratch profile and if done proper if the soft tissue dissection is good, they behave very nicely.
Okay, this the infix plate. It's actually it's called as a dorsal distraction plate, right?
We just call it a Acumed bridging infix plate. So
yeah, I think the concept is called as dorsal distraction plate for distal radius comminuted fractures.
Absolutely, you're distracting the joint using ligamentotaxis. Again,
and
making sure.
And I think the point you mentioned was if you have significant comminution in the subchondral area, that's when you're going for a dorsal distraction plate.
Correct. So your normal Volar plate, for example, will only work if you have sort of a metaphyseal comminution. If the comminution is way too distal, screws won't have purchase on those teeny tiny fragments. And sometimes when I go dorsally, it's like bone dust. There's nothing. There are like 20 fragments looking at you. So like a X-fix I use, a infix, same principle, is very easy to comprehend for exam going, not for you, Dr. Hitesh, obviously, for exam going at that level.
And the other one is, see, suppose you encounter a scaphololunate injury simultaneously. That is, there's some gap between the scaphoid and lunate while you're fixing a distal radius. How do you go about it?
I lost you, Dr. Hitesh. Please repeat your question.
Yeah, in case you have a scaphololunate ligament injury, and there is a gap between the scaphoid and lunate that's significant, and you're fixing the distal radius, how do you approach the scaphololunate problem?
Right. Okay. So what I have encountered mostly is distal radius is associated with a scaphoid fracture. but equally scapholunate ligament can go. If I'm certain on X-rays, there's a big gap in a Terry Thomas sign and everything, scapholunate angle is 90 degrees, more than 60 degrees on lateral X-rays. If I'm certain, then we know for the first 3 months, if you repair them, they behave very well. So I will then use a dorsal approach, one approach. I will repair the ligaments through that approach and put a dorsal plate, even though that X-ray that fracture was amenable to a Volar plate, because then you don't need to do 2 approaches.
And how do you protect the scapholunate ligament repair? I mean, you've repaired it and you've used anchors.
So it's a slightly big talk, but I'll try and put it in simple steps. You need to correct the scaphoid flexion and lunate extension. So use 2 wires as joystick, get your disc right, then hold it with a wire from scaphoid to lunate and a wire from scaphoid to capitate. That keeps your disc corrected. And then I use a washing line technique, like put an anchor in scaphoid and lunate for capsulodesis to make sure capsule slams back onto scaphoid and lunate, and all those dorsal septas will form. So basically is to make sure scaphoid sticks onto those carpal bones and those ligaments sort of form. Well, the ligaments scar up basically. So capsulodesis.
Dr. Saurabh, thank you for that very enlightening talk. There are no more questions, and we have had a very fantastic session. It's a pretty long one, but it's very exhaustive. And I think you've completely gone through all the entire spectrum of distal radius fractures. And we look forward for more from your side in subsequent days. And thank you very much for joining us. I'm sure it's hard for you. You've been in the hospital. In between your work, you're juggling finding time, and you're contributing towards education. Thank you so much for being with us, Dr. Saurabh, and looking for more from you.
I'm very grateful, Dr. Hitesh, for your kind opportunity. And yeah, before I leave, good luck, guys, and I thank you for taking out your time and for your kind attention. Thank you. And I'll liaise with you, Dr. Hitesh, and we can work out some other topics. It'll be a pleasure to sort of take more lectures.
Sure. Thank you so much.
Pleasure.